Thank you, Secretary. Up next, we have Dr. Susan Visser, who is from the Center for Disease Control in Atlanta. She's the acting Associate Director of Science in the Division of Human Development and Disability in the National Center for Birth Defects and Disabilities. She comes to us as an expert in attention deficit hyperactivity disorder, and as the Secretary mentioned, what we'd like for you to do as the audience today and as stakeholders in this process is to really be thinking about what she presents to us and what the other experts present to us from the standpoint of ideas that you, as members of this state, as policymakers, as clinicians, as family members, as concerned citizens can do with this information when you get back to your place of work or you get back to your residence. We really want you to think about that, take some notes. We'll be drawing from that this afternoon when we do our breakouts. So without further ado, Dr. Susan Visser, thank you.
Well, thank you. I really appreciate being here and being part of what I must say is one of the most thorough investigations and evaluations of ADHD treatment that I've seen within any state. And I'm really, really pleased to be part of this. I've been at CDC since 2001, and I'm the lead epidemiologist of the Child Development Studies team there at the National Center on Birth Defects and Developmental Disabilities, which is where we house our developmental disability work, autism, ADHD, Tourette syndrome, really trying to understand the epidemiology or the pattern of expression of these disorders, as well as trying to understand how do we improve quality of care for children who have these disorders, and also improve family outcomes and impacts. And I am an epidemiologist. I'm a doctor in public health. I'm a mother of 3 and a wife, a friend and referral source for any one of my friends or colleagues who have a child with ADHD. I'm not a medical doctor, however, and I want to make sure that that's clear. I was the committee epidemiologist for the American Academy of Pediatrics most recent revision of the Diagnostic and Treatment Guidelines. So I'll be talking a lot about that process and about the recommendations from those guidelines. But we have great clinicians here who can speak to some of the clinical aspects if you have questions about those. To begin, we're all here to talk about ADHD, and I think it's important to stay really grounded in the diagnostic criteria. And we know that there are social and environmental and biological components to getting a diagnosis of ADHD. And we start here with the gold standard for diagnostic criteria of ADHD, and it comes from the Diagnostic and Statistical Manual of Mental Disorders. These were revised back in May of 2013, and we had 2 important changes to the diagnostic criteria. We start with symptom counts, symptoms of inattention, hyperactivity, or impulsivity, and you need to have 6 or more to achieve a diagnosis of ADHD as a child. If you're 17 or older, DSM-5 revised the symptom count to require 5 symptoms or more, so dropping it just a little bit for those 17 years of age and older. And then we have what's called presentations, predominantly inattentive, predominantly hyperactive or impulsive, and then the combined subtype where you have both inattentive and hyperactive or impulsive symptoms. I was recently at the National CHAD meeting, which is the primary family advocacy group for ADHD and family support group. And Ben Leahy, who is a fantastic ADHD researcher and involved in developing these criteria over the years, really cursed himself for ever bringing up subtypes at all. Because it really implies that once you have a child who's diagnosed with a subtype, that's what they're going to look like for the rest of their lives. And the parents in the audience, whether or not you have a child with ADHD, know that behavior changes over time. And so if you have a child who is predominantly hyperactive and impulsive as a young child, you may start to notice over time that the inattentive symptoms start to take hold, and they become actually more impairing than the hyperactive and impulsive symptoms were at one time. So the presentations change over time and need to be revisited. There is an age of onset requirement for symptoms before age 12, and this increased from what used to be age 7 in DSM-4. And there has to be significant functional impairment, which is really important. It's not enough to just have the symptoms. You can have all 18 symptoms and not have significant functional impairment based on the parent report, for example. So you really have to have impairment. And then also pervasiveness. These symptoms can't occur solely at home or solely at school. You have to see them either with friends and at home or home and at school. that sort of thing. And finally, you have to rule out, as a clinician, other sources of these symptoms. For example, lead poisoning. Lead can cause symptoms of ADHD. Trauma, neglect at home, those can also cause these symptoms, as well as sleep disorders, which is a really important and sometimes difficult to diagnose a set of disorders that can cause these symptoms. Now, we are lucky to have not one, but two, at least, sets of practice guidelines from professional academies. One from the American Academy of Pediatrics that was recently revised in 2011 and includes now recommendations by age. We have recommendations for preschoolers, for elementary age kids, and also for adolescents. And it also is accompanied with a process of care algorithm, which was developed really to help primary care physicians walk through the process of diagnosing and treating children in a flowchart form, all the way through to treatment and management or referral or co-management with a specialist. We also have diagnostic and treatment practice parameters, is really what they're called, from the American Academy of Child and Adolescent Psychiatry. And these guidelines are really complementary. They are not at odds with each other. There's some information that's been updated based on newer research that we have, but they're very complementary. And here's the process algorithm that I referenced earlier, this flow chart to the right, which I know you can't read, but I just wanted you to see that they really endeavored to try to get this in a do this, then that, solicit information from these individuals, and then proceed on to the next step. And the AAP guidance really recommends starting with an evaluation for ADHD for any child who has ADHD symptoms and also experiences academic or behavioral problems. And they encourage using the DSM criteria that we just spoke about, that includes symptoms and impairment in more than one major setting, and strongly recommend that you collect information from parents or guardians, teachers, anyone involved in the child's behavioral health care, school and mental health clinicians, for example. And the clinician should really endeavor to rule out alternative causes, which can be really tricky sometimes, but really trying to do a good job there. And the clinician should also assess comorbidities, because it's more common than not that a child has another co-occurring condition, such as oppositional defiant disorder, conduct problems, a learning disability, anxiety, depression, those sorts of things. And a clinician should also recognize that ADHD is a chronic condition, and it will not likely desist in the next year to two after diagnosis. It's something that will likely persist for 2/3 of children who are diagnosed with ADHD as a child. They will have ADHD symptoms into adulthood. So when this percolates through the medical system and we get to diagnoses of ADHD, this is what it looks like nationally. In 2011 and 12, based on our largest national survey of parents about the health and well-being of children nationwide, we collect these interviews via the telephone from 80 to 100,000 families every wave that we do this. And we were conducting the survey every 4 years since 2003, and now it's going into the field for continuous administration starting in 2016, really directed and sponsored by the Maternal Child Health Bureau of HRSA. So we'll get really good annual data moving forward beginning in 2016. But in 2011 and 2012, the most recent data we have is that there are 6.4 million children, school-age children, 4 to 17 years of age, who've received a diagnosis of ADHD. And that's 2 million more than just in 2003, 8 years earlier. There are about 5.1 million with a current ADHD diagnosis and 3.5 million who are taking medication for ADHD. And that's 1 million more than in 2003. Now, this really reflects the national prevalence rates of approximately 11% of children nationwide having ever been diagnosed with ADHD, and that's up from 7.8% 8 years earlier, a 42% increase, or an increase of about 5% per year. And this has really been a linear increase that we've seen for some time now, and I'll show you that in a moment. About 8.8% have a current diagnosis, and more than 1 in 20 kids nationwide are taking medication for ADHD. That should say up from 4.8% in 2007, a 28% increase, and that's about an increase of 7% per year. Okay, so this is a slide that really shows you that whether we go into homes and we ask parents about diagnosed prevalence of ADHD, or if we call them on the phone, we're seeing increases of about 3 to 6% per year since the late 90s in diagnosed prevalence of ADHD. And you can see that in another format when we look at what we call a population pyramid. And I'm going to orient you to this slide because the next three are going to follow the same format. Boys are on the left, girls are on the right. age is running up the middle from 4 to 17. And if there's any way to darken the room a little bit, I think this would be a little more successful. Maybe drop a window or something. But what we see is that in the inner bars are the percentage of children who have been diagnosed with ADHD and they're currently taking medication. And the outer bars are the children who've ever been diagnosed with ADHD. So you can see, I hope we don't put people to sleep, but that's better. Is that better for people? Okay, that's great. We'll adjust. So you can see that the diagnosed prevalence of ADHD increases into elementary school and then starts to decrease after middle school into high school. And certainly for medication treatment, we see this pattern, this curvilinear pattern where medication increases and then decreases into high school. Now, as we move into 2007 and 2008, the red bars that have been added are the children who have a current diagnosis of ADHD, but they're not currently taking medication. So I'm just going to pivot back and forth, moving from 2003 to 2007. You can see that the absolute size of the pyramid has increased quite substantially, and also the medication bars have really increased independently. And you see that there's this really precipitous increase, particularly for the boys, from 4 to about age 8 and 9. And then more of a stability in terms of diagnosed prevalence. And we're still seeing a little bit of a decrease in medicated ADHD for the older boys. For the girls, it sort of increases and stabilizes. And then moving from 2007 to 2011, again, a really precipitous increase. And what we see, is by high school, about 1 in 5 boys have been diagnosed with ADHD by high school, and nearly 1 in 10 girls. And that's nationwide. So when we look at age of diagnosis, we find that the average child is diagnosed with ADHD by age 7, but there's certainly a relationship between age of diagnosis and severity of ADHD. And children with severe ADHD are diagnosed at average by age 5. And this is interesting because it represents not only an opportunity for intervention for our youngest kids, but it also suggests that there may be a phenotype here, where children who have the severest forms of the disorder, present very early. These are the children who are kicked out of preschool, sometimes numerous preschools, and really they need our help to try to address the behavioral problems with the right treatment. And so I hope today will be a day of discussing how to bring the right treatment to especially these young children who present early and then are later described as having severe ADHD. Now, when I talk about a phenotype, I'm talking about a group of children who present and they look differently from the other children. And we do know that there are serious biological underpinnings to the diagnosis of ADHD. We do know that there are some social and environmental components to who gets the diagnosis and who gets the medication, but we also know that underlying all of this, in children who have ADHD, they have anatomical differences. And you can see some of them here. For children with ADHD in adolescence, the frontal lobe size and temporal lobe size are smaller than in their non-ADHD peers. And also, there's more gray matter in children with ADHD in their temporal lobes. We also know, for the first time, really, that there is a group of children who have what is considered a developmental delay, ADHD as a developmental delay. And we found this through Dr. Philip Shaw's research at the National Institute on Mental Health. And there at NIH, he did multiple brain imaging scans, so MRIs, of more than 200 children with ADHD and more than 200 controls. And they're all, really sort of middle to upper class white children, unfortunately. But their brains shouldn't fundamentally be different. And what they saw was that when they scanned these children from age 10 to until about age 17, they saw that the natural brain growth and then cortical pruning process that happens in adolescence was delayed by 2 to 3 years among children with ADHD. And for some children, that brain growth and cortical pruning process that makes the brain more efficient doesn't happen for everyone, but for a small group of children, a meaningful but and small group of children, they're just delayed. And once they catch up, once that cortical pruning and brain growth process catches up, the symptoms of ADHD desist. They no longer meet criteria for ADHD. So this is an important component of the diagnosis. It definitely does not happen for all children with ADHD, but the authors concluded that some children will outgrow ADHD when their brain development catches up. However, the impairment that they've experienced during this time in early, middle childhood, and even into early adolescence could be felt long-term. And so helping them deal with these impacts is really important. And then for other children, they'll never catch up. And this process either does not happen or happens much, much later. And so we can expect that there are impairments that will remain with these children. So what do we know about the persistence of symptoms over time in children with ADHD? This is a paper that was e-released already, but it'll be in print in January in the Journal of Attention Disorders. And we took some of our community-based studies that we do in communities across the United States, and this is from South Carolina. We looked at the expression of inattentive symptoms over time, and then we also looked at the hyperactive impulsive symptoms over time, and you can see that they track together. And when we collapse them, because they track so well together, we see that children who have inattentive symptoms will continue to have inattentive symptoms. Children who have the hyperactive and impulsive symptoms will see a marked decline over time, so that by late adolescence, only about 10% have these hyperactive impulsive symptoms. And I think that's really important for anticipatory guidance, for families to understand what to expect, and that the disorder will change, and the symptoms that they're experiencing in their 4, 5, 6, 7-year-old will change over time, but that those inattentive symptoms will continue to challenge the child's executive functioning, their ability to plan and organize, and really control impulses. That really extends from some of these inattentive symptoms, and the executive functioning challenges can be really difficult for achieving in the academic environment, completing high school, going to college. Those things are going to be really, really difficult and require some intervention. So we're going to pull up now to the population level. And I find this really fascinating, and by far the media asks the most questions about these patterns, and I understand why. For ADHD, we see really remarkable patterns in terms of state-based variation for diagnosed and medicated ADHD. And this has always been true since the beginning of 2003 when we started looking at this. There is certainly an east-west gradient where we have much lower prevalence of diagnosed and medicated ADHD in the West. And the states that have the highest rates, however, have been shifting around a little bit, but they remain over to the east. It used to be very heavily concentrated in the south, and now it's a little more distributed. But you can see that the national average for current ADHD is 8.8%. Louisiana finds itself at 13.3%, which is ranked third nationally for children 4 to 17 years of age. When we move on to the percent medicated among those with ADHD, approximately 80% of children in Louisiana who have a current ADHD diagnosis are taking ADHD medication. And that's neither a good nor a bad thing. I have lots of questions. People ask me, should that be 100%? Some psychiatrists that I've spoken to have said, that should be 100%. We know medication works, and all our children should be on it. Someone at CHAD actually told me that it's unethical not to intervene with medication, given what we know. It's not that simple. Certainly there is a lot of family choice that goes into this, and also depending on the co-occurring conditions that the child has, you may be much more successful with behavioral intervention. So this is a complicated statistic to interpret. But I do want to say that when you look at the overall rate of medicated ADHD in Louisiana, it's in excess of 10%. It's 10.4% of children 4 to 17 years of age in Louisiana are taking ADHD medication, which puts Louisiana at the top of the stack in terms of the highest rank for medicated ADHD out of all states. Okay, so we're going to dive in and take a closer look at Louisiana for a moment. If you haven't seen these, I would encourage you, if you're at all interested in state-based estimates, we have a state page, a state profile page for each state. And here's Louisiana's, and you can see at the very, very top, we put the state-based estimates since 2003 against the U.S. Patterns, and you can see that Louisiana has been outpacing the United States increases for some time now. And then you see the state ranking in the green row there. Louisiana ranked third highest for current prevalence and ranked first highest for medicated prevalence. Now, we are able to dig in a little deeper with the National Survey of Children's Health and look at your state estimates against the United States, and these are a simple reminder of what we just talked about, that Louisiana is in excess of the U.S. Estimates for current ADHD and current medication use. But looking within Louisiana, you can see some of these gender patterns and some of the patterns by specific demographic groups. And here you see what is pretty common. We usually see somewhere between a 2 and a 3 to 1 ratio of boys to girls for medicated and diagnosed ADHD. In Louisiana, you're trending a little closer to the 3 to 1 ratio, which I think is really interesting, and we'll talk in a little bit about that. When we look by age, we see that the highest rates are for the 11 to 14-year-olds. I think Ryan's got some really interesting information that gets at a better level of specificity than I can in these grouped age ranges, but I wanted to point this out. And then when we look at these rates of diagnosed ADHD, current ADHD, and current medication use as a function of type of insurance, we see that the lowest rates of current ADHD are among the privately insured children in the state, and that the lowest rates of medication use are, of course, among those who don't have health insurance, which is actually a pretty small number in your state. So looking again by insurance status, Louisiana overall versus Medicaid, you can see that the rates among Medicaid are just a little bit higher than the overall state estimates for ever diagnosed current ADHD and current medication. Nothing really remarkable here. But what I do find interesting is these are gender differences for the United States overall, and you see that really we're at a 2 to 1 ratio nationally of boys to girls, where twice as many boys are diagnosed with ADHD or have a current diagnosis of ADHD, and twice as many are taking medication for ADHD. When we move over to Louisiana, we see that that ratio increases, and more boys proportionately compared to girls are diagnosed with ADHD and are taking medication for ADHD. But then when we move into Medicaid, the gap widens even further. So I think there's something really interesting about likely your boys in poverty in Louisiana that I think warrants further consideration. Now, this is obviously not Louisiana. This is Georgia, my home state. And we looked at some of these estimates as a function of county. And so we saw a really great variation across states, but we also see great variation across even the county level. And if you look on the right-hand side, what we see in Georgia among adolescents 11 to 17 years of age, we see as few as 4% of adolescents being medicated in some counties compared to almost 18% in other counties. And the highest rates of medicated ADHD are actually founded not in the urban settings, where I certainly hypothesized in that paper that's under review currently, but rather in the rural populations. And I propose a theory that perhaps it's because of a lack of access to behavioral services. So briefly, I'm going to talk through what is recommended for treatment. So we talked about how you diagnose a child based on best practices, but how do you treat a child based on best practices? And the American Academy of Pediatrics, in their revised guidelines, as I mentioned, splits it out into these 3 groups. And for preschoolers, they really recommend for 4 and 5 years of age, you should use behavioral therapy as first-line treatment. And why did they do that? I sat in and I watched these clinicians really wrestle with trying to provide guidance to clinicians who were being faced with young children who are coming into their offices and looking for assistance with ADHD symptoms and really not knowing what to do with them. And they were doing it on their own. They were making the best decisions they could at the time. And so they wanted to provide guidance. But at the time, there was very little information. We do have the preschool ADHD treatment study, the PAT study, which was a safety and efficacy trial of methylphenidate. And even though short-acting amphetamine, the Adderall, short-acting Adderall, is FDA approved for ADHD treatment for children as young as 3, they really felt that there was better evidence around methylphenidate because of the PAT study. And so recommended that if you can find behavioral therapy, if you can get behavioral therapy for these young children, you really need to do that because there are adverse events that are associated with ADHD medication treatment for all children, but especially for young children. And I'll talk about that in a moment. If you try behavioral therapy for at least 9 months, you've tried many different things and it's just not working, and you have persistent functional impairment and the child is really in danger to self or others, or you really just need to intervene, then you can try a short course of methylphenidate and very, very carefully titrate it. But they warn that you have to weigh the risks of starting medication at an early age, and we don't have very much information, if any information, about the long-term impacts on preschoolers of these medications against really the risks of failing to intervene. And we know that there are some very, very serious and important negative outcomes associated with ADHD long-term if left untreated. These include unintentional injury, more motor vehicle crashes, certainly failed academic achievement, lower rates of high school graduation, lower rates of entry into college and completion of college, lower attainment, employment attainment, much more frequent layoffs and termination of jobs. And Biederman and Barbarisi have some really interesting data on the costs associated with the societal impact of ADHD among adults, and include really high rates of psychiatric comorbidity as adults and even earlier death. So we're talking about some serious impacts for our kids with ADHD, and so there is really no disagreement from any of the professional academies. Treatment is extremely important, and it's finding the right treatment for these kids and doing it right from the very beginning. So children who are in elementary school, the recommendation is really to try to combine both ADHD medication and behavioral therapy, of course considering the family's preferences. And then for adolescents, there's really not much data out there that suggests that behavioral therapy is going to have a huge impact. So they really recommend medication treatment and behavioral therapy if it's available. So we're going to dive into a closer look at preschoolers with ADHD. And why do we do that? Well, to begin, I think that being within child development myself and having a degree in developmental psych, I think it's really important to think about the entire developmental curve of how these symptoms express themselves and when they begin. And when they begin early on, as we see here, and because we know that severe ADHD can be identified very early on, we need to really consider how we are treating these children and how carefully we're approaching them with getting the right treatment. So we start with the epidemiology of the ADHD diagnosis and medication treatment among preschoolers 2 to 5 years of age. And what we find is that a little over 1% nationally of our preschoolers have a current ADHD diagnosis, and about half of them are currently taking ADHD medication. And that means we have about 194,000 preschoolers nationwide that have current ADHD. And about 77,000 of them are taking medication for the disorder. Now, when we look at changes over time, we see that in 2007 and 2008, the rate was just under 1% for diagnosis, and now is at about 1.5%. And so that's an increase of about 56%. And the increase in medication treatment has been 100%, a doubling in the percentage of children taking ADHD medications who are between 2 and 5 years of age. Now, as we would expect, there are regional variation. I can't do state-based variation because the numbers get too small for even my large national survey data. But we do see, looking at these 9 regions of the United States, that there's still in sort of central United States really high rates relative to the West for ADHD diagnosis among preschoolers. And we also see that treatment rates are higher among the Midwest to the East compared to the West. So the national rate for ADHD medication for preschoolers is about 40% nationwide. And then for behavioral therapy, this is using the only data we have that includes both ADHD medication and behavioral therapy. We see that there's really an inverse. So I'm going to toggle back. This was the medication map, and here's behavioral therapy. There's really an inverse relationship. And when you run a correlation on this, you see a negative relationship, an inverse relationship between behavioral therapy and medication treatment. And that gives us a clue that there may be some elements of availability of behavioral therapy here driving some of these patterns. Okay, and then this is a complex map that I don't want to talk about too much. We were trying to get at the percentage of preschoolers who are not receiving either medication nor behavioral therapy. We really didn't have fantastic estimate stability. Those crosses indicate that we have really large relative standard errors, and so I don't want to interpret it too much. But I do want to say that there are children in the United States, preschoolers, who clinicians are probably taking a more wait-and-see approach, and that's also probably appropriate for a large number of children, trying to understand where the symptoms are coming from and how do we account for them. And with that, I'm going to pause and pop out, and Mr. Bilbo is going to give me a break while he talks a little bit further about what he has found in Louisiana. using your own data.